Assalamu alaikum and good day everyone. This is a lecture on acquired heart diseases in children. Let's start with a case scenario. A 9-year-old girl, with no known medical illness, was admitted with progressive shortness of breath for 5 days associated with orthopnea. She also had history of fever associated with sore throat 2 weeks previously. On examination she was afebrile. Her blood pressure was 110/60 mm mercury, pulse rate was 140 beats per minute, respiratory rate was 36 breaths per minute, oxygen saturation was 96% under room air. Her apex beat was at 6th intercostal space anterior axillary line. On auscultation there was a pansystolic murmur grade 3/6 at mitral area radiating to the axilla. She also had bibasal crepitations and bilateral ankle edema. Based on the scenario given, please answer the following questions. What is the most likely diagnosis? Name the etiology of this condition. State the investigations that can help to confirm the diagnosis. State the treatments indicated in this patient. I hope you will be able to answer all these questions after listening to this lecture. At the end of this lecture, the student should understand the pathophysiology, main clinical features, investigations, and principles of management of acute rheumatic fever, infective endocarditis, and Kawasaki disease in children. Let's start with rheumatic fever. Acute rheumatic fever is a post-infectious inflammatory disease which occurs after tonsillopharyngeal infection caused by Streptococcus pyogenes. The peak age of incidence is between 5 and 15 years old. It's now rare in the developed world, but remains the most important cause of acquired heart disease in children of developing and underdeveloped countries. This slide illustrates Jones criteria which is used to diagnose rheumatic fever. Major criteria are carditis, arthritis, Sydenham chorea, Erythema Marginatum, and subcutaneous nodules. Minor criteria are temperature more than 38 degrees Celsius, raised erythrocyte sedimentation rate more than 30 mm per hour, elevated C-reactive protein more than 30 mg per liter, and prolonged PR interval on electrocardiogram. In the next few slides, I will explain in more detail the major Jones criteria. Carditis is the inflammation of the heart which can be endocarditis, myocarditis or pericarditis. Endocarditis is the inflammation of endothelial lining of the heart including heart valves resulting in regurgitation or stenosis. The commonest valves affected are mitral and aortic. Myocarditis is the inflammation of myocardium or heart muscles. Pericarditis is the inflammation of pericardial layer of the heart, which can lead to pericardial effusion and cardiac tamponade. Arthritis in rheumatic fever most commonly affects the ankles, knees, elbows and wrists. It can migrate from one joint to another, hence the term migrating polyarthritis. Sydenham chorea in rheumatic fever is characterized by rapid, involuntary, random, and irregular movements, especially of the face and limbs. Erythema marginatum is pink or red, macular or papular rash, which spread outwards in circular shape. As the lesions advance, the edges become raised and red, with clearing up of the center. The lesions are not itchy or painful, and sometimes go unnoticed by the patient. They can also fade and reappear within hours. Subcutaneous nodules are uncommon, occurring in less than 2% of patients with rheumatic fever. The painless nodules are found over joints such as the elbows, knees, ankles, and knuckles, the back of the scalp, and the vertebrae. They are firm, round and mobile, ranging from 0.5 to 2 cm in size. This slide shows the investigations that you should perform in patients suspected to have rheumatic fever. Full blood count may show leukocytosis. Erythrocyte sedimentation rate and C-reactive protein are raised. Elevated anti-streptolysin O titer, positive throat swab or blood culture for group A streptococcus give evidences of streptococcal infection. Electrocardiogram may show prolonged PR interval, which is a minor criterion for acute rheumatic fever. Chest X-ray may demonstrate cardiomegaly and changes suggestive of heart failure, such as increased pulmonary vascular markings in patients with carditis. Echocardiography may reveal valvular regurgitation, especially of mitral and aortic valves, and pericardial effusion if there is pericarditis. In order to make diagnosis of acute rheumatic fever, the patient should have two major criteria, or one major and two minor criteria, plus evidence of preceding group A, streptococcal infection. The aims of management of acute rheumatic fever are to provide symptomatic treatment, shorten the acute inflammatory phase, and treat the streptococcal infection, followed by secondary prophylaxis. Bed rest is especially important in those with carditis and arthritis. Anti-failure medications such as diuretic and angiotensin-converting enzyme inhibitor are given if the patient develops symptoms and signs of heart failure. Penicillin for 10 days is recommended to ensure eradication of the group A streptococcus. Anti-inflammatory therapy with aspirin is indicated for arthritis or mild carditis, however we should add prednisolone if the patient has moderate to severe carditis. Secondary prophylaxis is crucial to prevent recurrence of rheumatic fever. The antibiotic of choice is penicillin, which is best administered as intramuscular injection of benzathine benzyl penicillin once every 3 weeks. Daily oral penicillin is a less desirable alternative due to compliance issue. Patients with penicillin allergy can be given oral erythromycin. This penicillin prophylaxis should be taken until the age of 21 years, or 5 years after last attack of acute rheumatic fever, whichever was longer. Patients with valvular involvement need to take the prophylaxis lifelong. Now I will talk about infective endocarditis. It is defined as an infection of the endocardial surface of the heart, which may include the heart valves, mural endocardium, and septal defect. The risk factors for infective endocarditis are: unrepaired cyanotic congenital heart disease, repaired congenital heart disease with prosthetic material or device, prosthetic cardiac valve, past history of infective endocarditis, and presence of central venous catheters. The etiologies of infective endocarditis include Streptococcus viridans, being the commonest, Staphylococcus aureus, Streptococcus bovis, and the Hasek group. This Hasek group of organisms are more common in the neonates and immunocompromised children. In terms of symptoms, patients with infective endocarditis usually have fever of more than 1 week. They may also have loss of appetite and symptoms of heart failure such as shortness of breath on exertion, orthopnea and paroxysmal nocturnal dyspnea. On examination, clinical stigmata of infective endocarditis include Janeway lesions, splinter haemorrhage, Osler's nodes, and Roth spots. New or changing heart murmurs are noted in many patients. Splenomegaly is a common finding on abdominal examinations. In the next few slides, I will explain in more detail the stigmata of infective endocarditis. Janeway lesions are flat, painless, and erythematous lesions seen on palms and sole. Osler's nodes are erythematous, tender nodule on pulp of fingers and toes. Splinter hemorrhages are dark red, linear streaks in the nail beds of the fingers and toes. Roth spots are retinal hemorrhages with pale centers. Diagnosis of infective endocarditis is made using modified Duke criteria. The details can be found by clicking the link given in this course content. This slide shows the investigations that you should perform in patients suspected to have infective endocarditis. Full blood count may show anemia, leukocytosis, and thrombocytosis. Erythrocyte sedimentation rate and C-reactive protein are usually elevated. Blood culture may reveal the growth of causative organism. Urinalysis typically shows the presence of hematuria secondary to acute glomerulonephritis associated with infective endocarditis. Echocardiogram should be done to look for presence of vegetations. Now I will talk on management of infective endocarditis. Taking 3 separate blood cultures from different peripheral sites within 24 hours is recommended before commencement of antibiotic therapy. The empirical antibiotic of choice is combination of intravenous penicillin and gentamicin. Prolonged parenteral therapy is the only way to achieve bactericidal serum levels to kill all the bacteria present in a vegetation of endocarditis. Treatment duration generally ranges from 4 to 8 weeks. The use of prophylactic antibiotic before certain procedures is recommended for patients at high risk of developing infective endocarditis as mentioned earlier. The prophylaxis should be given 1 hour before dental procedures such as dental extraction and respiratory procedures such as tonsillectomy. Amoxicillin or ampicillin is the antibiotic of choice. However, if the patient is allergic to penicillin, azithromycin, clarithromycin, or cephalexin can be used as alternative. Now let's discuss Kawasaki disease. Kawasaki disease is a systemic vasculitis which mainly affects children between 6 months and 5 years old, with peak incidence at the end of the first year. The diagnosis is made based on clinical criteria which are fever for at least 5 days, and at least 4 out of the following 5 clinical features: mucosal changes of the oropharynx, cervical lymphadenopathy, changes in extremities, conjunctivitis, and rash. Apart from that, the illness is not explained by other disease process. In addition to the above features, the affected children are generally irritable, and they may also have inflammation of their BCG vaccination site. In the next few slides, I will explain in more detail the clinical diagnostic criteria for Kawasaki disease. This slide shows mucosal changes of oropharynx in Kawasaki disease, which include strawberry tongue, and red, cracked lips. Other feature is red throat. The cervical lymphadenopathy is usually unilateral and should be at least 1.5 centimeters in diameter. The changes in extremities initially start with redness, edema, or swelling of palms and sole during first week of illness, followed by peeling of the skin during the second and third weeks. The conjunctivitis is typically bilateral and non-purulent. The rash is polymorphous, maculopapular, erythematous, and mostly seen on the trunk. This slide shows the investigations that you should perform in patients suspected to have Kawasaki disease. Full blood count may show anemia, leukocytosis, and thrombocytosis. Erythrocyte sedimentation rate and C-reactive protein are typically elevated. Liver function test may show low albumin and elevated alanine transaminase. Urinalysis may show presence of leukocyte. ECG may reveal ST elevation, which indicate myocardial ischemia. Echocardiogram should be performed to look for coronary artery aneurysm. Treatment of Kawasaki disease. The main complication of Kawasaki disease is development coronary artery aneurysm, which can lead to myocardial infarction and death. Intravenous immunoglobulin is the mainstay of treatment and has been shown to lower this complication if given within the first 10 days of fever. High-dose aspirin is used as anti-inflammatory at the initial phase of treatment. Subsequently, it is used as antiplatelet to reduce the risk of thrombosis in patients who develop coronary artery aneurysm. In summary, rheumatic fever, infective endocarditis, and Kawasaki disease are important acquired heart diseases in children. Acute rheumatic fever is diagnosed using Jones criteria. Infective endocarditis is diagnosed using modified Duke criteria. Kawasaki disease is diagnosed using clinical criteria.